and give us the courage to speak truth in a time where it is very difficult for people to hear your voice in all that we do. So we pray this and ask your blessing with us today, and we pray in the name of the God who sits high but looks low. Amen. So Dr. Gar, I'm turning it over to you, and thank you for y'all's work and all you've been doing for many years around issues of HIV, but now you're focused on trying to address a vaccine for COVID-19. So Dr. Gar.
Thank you, Dr. Morris, and thank you to colleagues at Church Health who have made this webinar possible. A big thank you to colleagues who I cannot see but are listening to this webinar for taking the time in the middle of the day or later to listen to this exchange of information and ideas and questions. And I underscore the exchange because this is not meant to be just us sharing information, but us learning from you about the questions you and the community may have, such that we can, in a most informed way, share information that then allows people to make decisions. So as I pull up my slides and share my screen, so I can use some help. Normally, the screen sharing is seamless, but I'm seeing a prompt for open system preferences. Are you able to see my screen now?
Yes, Dr. Gar, thank you.
Thank you. So on the webinar today with me are my colleagues, Andrea Stubbs. Andrea, many of you may know, but she leads our community outreach program and works with a coalition of 25 plus stakeholders in Memphis, both from the faith-based community, non-government organization, and brick and mortar healthcare institutions. Dr. Flynn is the co-primary investigator for this vaccine trial and the deputy clinical director at St. Jude Children's Research Hospital. She's my mentor, and her work in clinical care and research now is for over 3 decades at St. Jude. So, and then briefly about myself, I am a pediatrician who came from India in 1996 and have been at St. Jude for now over 2 decades, providing both clinical care and active in clinical research. And as Dr. Morris mentioned, a lot of our work is for HIV prevention and treatment. So with that introduction, this is a photograph of the virus, with the point being that there are attributes of the virus which are exploited to develop a vaccine. The way a vaccine works, as you all know, is to give not a live virus, but pieces of the virus to oversimplify, such that when those pieces are injected into a human being, the human being mounts an immune response such that when the real virus is seen, the body already has ways of fighting it. So it's, while we are inundated in media, in the press, and through other ways for numbers, it's important that we start with the backdrop of where we currently stand with COVID-19. This is a clipping from the New York Times earlier this morning, which shows a very large number of COVID-19 cases in this country, with unfortunately over 220,000 deaths, and a trajectory which shows that while there was some decrease over the past couple of months, the number of cases are on the rise. This is a snapshot again from this morning of what the numbers look like in Shelby County, which shows that we do share a large burden of the COVID-19 infections and unfortunately related deaths. And we all remind ourselves that for many of us, these may be numbers, but for some, these may be people they know or from their own family. As is true for many infectious diseases, so is it true for COVID-19. There are disparities in who it affects, where it affects, and shown here is a plot of zip codes in Shelby County. The darker the color in red, the more is the case count in those counties, zip codes. There is also a disparity in who, when infected, succumbs to the infection. And shown here is as the age of the person with COVID-19 infection is more, so is the fatality associated with infection, with a disproportionately large amount of deaths in those who are 55 or above. The disparities are also in terms of race, ethnicity, and shown here is Shelby County data of case fatalities associated with COVID-19, showing that unfortunately, a majority of these deaths have occurred in those who identify themselves as Black African American. And there is also a difference in terms of case fatality based on underlying conditions that a person may have when they get COVID-19 infection. It's striking how the number of deaths are clustered in those with an underlying cardiac condition, and this may include high blood pressure or diabetes or underlying respiratory conditions. What's also very apparent as we have seen the disease travel around the globe, that it's highly infectious. And I find this figure particularly compelling. One member of a choir with 87% of the group infected from that one person, because in that setting, the absence of a mask, some mild symptomatology, and grouping of an individual created the perfect storm in terms of the rapid spread of infection. I also remind ourselves that not only is it highly infectious, but it has the ability to transmit from someone who is infected but does not have symptoms. So with symptoms, we put on the safeguards of perhaps staying at home, perhaps covering our mouth when we sneeze or cough. But if someone is not aware based on any symptoms that they are infected and could transmit infection to others, that again makes this virus hard to control. So shown here is from 3 children who did not have symptoms to 12 adults who were in their contact who got infected to 1 parent who required hospitalization. This is what is driving the ongoing spread of infection in the community. And this is the basis for what our community is focusing on, which is the message of wearing a mask, maintaining 6-foot distance, and good hand hygiene. So why is a vaccine needed? We see a highly infectious virus. Shelter at home, including in our county, worked, but it cannot be sustained. Masks, physical distancing, and hand hygiene are working. We wish it could be more prevalent in terms of people following these and using these, but again, are difficult to sustain day in and day out. And in this setting, reminiscent of the history of infectious diseases, an effective and safe vaccine could really make a difference. And so shown here are examples of infections which mankind has seen and developed vaccines against. And some to note, like diphtheria, smallpox, polio, are where the effectiveness of the vaccine is 100%. Some of you may know this or remember this, but these are pictures of what polio can do and what we do not see any longer because of a global vaccination. This is a picture of smallpox in a child in 1972 in Bangladesh, a condition which no longer do we see, and it is credit to a vaccine. And so vaccinations to address infectious diseases have a long and strong history. And what's remarkable for COVID-19 is the number of stakeholders who have come together, be it from our government, research institutions, academic institutions, the community, the industry partners, to make what is typically a timeline that stretches over years be far more quicker, but not compromising safety. And that's a little bit of the story that we want to share with you. Before going into that, reminded by colleagues last Monday, where we shared some of this information and who reminded us that history is still very much part of and informs perspective of many of us in the community about how we view healthcare in general and research in particular. So I want to spend a few minutes talking about the evolution of clinical research. Randomized clinical trials sounds very nerdy and sounds very technical, but it's important for us to just dwell on for a minute. It's considered the gold standard of clinical research, and it is the ability to take a population and randomly, without the bias of the investigator, assign something to what is promising, be it a vaccine or a drug, and some who are either not given anything or given a placebo, without the individuals and the investigators knowing who was assigned what. Why this is considered as a gold standard is, when done this way in an ethically appropriate fashion, with everyone aware of what is being done, this gives the ability to truly see if something is effective or safe without any bias of anyone, be it the investigators or the participants. And so the first randomized trial was with an antibiotic which was used to treat tuberculosis, and it was in 1946. But then what went wrong, and Dr. Morris already introduced about the Tuskegee syphilis study, and many of you are aware and may have followed during those times as the information about this was unveiled. But in 1932, when there was no treatment for syphilis, a well-intentioned effort, and I cannot speak to it because I have not lived those times, but a well-intentioned effort to see what is the clinical course of syphilis in those who are infected with syphilis, not purposefully, but by nature, in an uncontrolled fashion. How they do over decades was initiated. It took until 1972 to highlight what were the things that went wrong with this trial. In 1997, when the first public large-scale apology for what went wrong with this trial was issued by President Clinton, and shown here in the picture is one of the study participants who was 94 years of age when this picture was taken. What went wrong with this trial was the important components of an informed consent were lacking. Informed consent is not signing a document. It is the beginning of a process which continues from the day you share information with anyone, such as this webinar today, to the day a study gets over, and after that, as new information comes. It's that process of sharing which builds trust, where one shares with someone what a study is about, what are their rights, and shares with them that as new information is learned, they will be informed about it. In this particular study, the participants were aware of some, but not all, of what the research study was about. Just after World War II, when penicillin, an antibiotic that treats syphilis very effectively, became available, these study participants were not made aware that giving treatment with penicillin could change their clinical course, not for a year, not for a decade, but for many decades. This is a blatant problem with the components of what's considered informed consent. And so the fallout of this was many regulations, but a key report which underpins the ethical safeguards of research in contemporary times is the Belmont Report, with three main principles. Respect for persons. It involves recognition of personal dignity and autonomy of individuals and special protection of those persons with diminished autonomy. So those would include children, the elderly, those who are incarcerated, special provisions to make sure there is respect when they are being considered or offered research, and there's no coercion. Beneficence, which entails an obligation to protect persons from harm by maximizing anticipated benefits and minimizing possible risks of harm. And justice, which requires that benefits and burdens of research be distributed fairly. And I want to pause on that last point, which is the benefits and burdens of research distribution fairly includes also taking the message of research and all the information that accompanies it to everyone in a fair and in an informed fashion, being able to communicate that. Because just like doing research without transparency on a select group of individuals is very wrong, so is it wrong to conduct research in populations not most affected and then say that these research results are generalizable to all. So today's standard of care, whether it's the metformin you take for diabetes, or the blood pressure medication that you take every day, or the pill that we take for allergies, or the flu shot that we take every year, is made possible by studies and research of yesterday, and most importantly, those who participated in it. And we continue to be humbled by seeing this day in and day out as part of conducting clinical research here with our team. This reminds us that we are not all alike. We are different in age, gender, race, ethnicity, our genetic makeup, the environment that we live in. So depending on the condition, in this case, we already saw with COVID-19, how a infection affects us, how we respond to it, what are our chances of succumbing to it, what is our immune response to it, it differs. So with this diversity, if this diversity was not reflected in the studies that were done, including for a vaccine, then we would not have the complete information to then take that as part of standard of care. We may all share the same appearance as in being all human beings and offer the same health care, be it a vaccine, but there is variable response among us. And rather than learn about it when millions of doses are given as part of a program, which is a standard of care program, it is very important that we bring in that diversity upfront when the clinical trials are done. And that's where we seek your help. So with that backdrop and mindful of what research is, why research is important, and how research is done, there are, in a very short period of less than a year of having known this virus, a tremendous amount of research activities around the world. And shown here are the number of clinical trials at different phases that are currently ongoing, but not yet a approved vaccine. And just to share with you, as trials go from phase 1 to phase 3, so do the number of participants that take part in it. Phase 1 is the initial trial where a small group, typically of healthy volunteers, are given, be it a medicine or in this case a vaccine. Not only their safety, but their immune response is looked at. If that is promising, then it goes into a larger trial. If there the safety and effectiveness is shown as promising, it goes into an even larger trial. So this phase 3 trial, which we share with you and which is part of at least 5 that will be opening or have opened in this country by the end of this year, is targeted to enroll as many as 60,000 participants, both in the United States and outside the United States. But it's been planned such that depending on the number of COVID cases that happen in trial participants, the trial can be stopped early if there is an early indication that the vaccine recipients show a effectiveness compared to those who got the placebo. Operation Warp Speed is what we have heard in the media. And what that is a unprecedented collaboration between many agencies, including the Department of Health and Human Services, the National Institute of Health, and the Department of Defense, to collate their resources and their experience and join hands with industry partners like Janssen and others and take these vaccines into clinical trials and enroll on them. I pause here to say, while it's been purposefully named this way to say there is a sense of urgency because a lot depends on these vaccines in terms of public health implications around the world. But that speed is not at the cost of safety. It's very regrettable when there is talk about deliverables by election day. There is talk about promises that should never be given before research is completed. It's very regrettable that these distract and frame discussions of science and research, but that is not how research studies are conducted, including for these vaccines. And I'll share some on this with you when we talk about the safety safeguards. But the purpose is that not with just one effective vaccine, hopefully we'll have many effective vaccines and many industry partners producing millions of doses can we saturate the globe with the number of doses that are needed around the world? This is the timeline of the various studies that are underway or soon to be underway. And on here, the trial 3003, which is the Janssen study, which is what we have an opportunity to open here in Memphis. It's noteworthy that it is one of the vaccines which so far has shown effectiveness with a single dose. For the other vaccine trials, right now, 2 doses, 1 month apart, are being looked at. But for this particular trial, everything so far indicates that a single dose may be effective. These are the number of centers with experience conducting clinical trials around the United States, which just like us are doing just like what we are doing, which is sharing information about the clinical trial or clinical trials that are open at their institution with their community and asking for help to spread the message about the trial in the community. The trial that we are soon to open is called the Ensemble study. It is a randomized clinical trial, and we talked a little bit about what that means. And shown here are few of the key highlights about this study. This is part of the collaboration between the stakeholders of Operation Warp Speed and one industry partner. The investigational product is a single vaccine dose, which so far in the laboratory and in the human data to date shows safety and effectiveness. But a phase 3 trial is now needed and is open to enrollment. Its primary objective is to show the effectiveness of this vaccine. It is designed to enroll up to 60,000 participants worldwide, but it does not have to be that 60,000 participants are enrolled. It may be that if effectiveness is shown earlier, then the trial could be potentially stopped. The study population is 18 and older with no upper age limit, and the trial has phases, but it would be fair to say that individuals with comorbidities, where, as I shared earlier, if someone gets infection, the risk of getting complications or even death related to those infections is high. Individuals with such condition are not excluded, but purposefully invited to be part of this study. And that goes to the point of, if you design trials with just a select population, then how can it be applicable to those who most need it? It is important to have representation of individuals who ultimately would benefit from the vaccine. Half of the participants will receive the study vaccine and half the placebo, and the participants will not know, the researchers will not know, but the core team will know, and that's the team which will periodically look at the results, the differences between the study arms, and is responsible for, when it sees a significant difference, of then alerting and stopping the trial. A question some of you asked and Lizzie shared was around what is known so far about the safety of this vaccine. If everything is known about the safety of a medicine or a vaccine, then there is not a research trial needed. The research trials are what incrementally start to provide that information. And so shown here are what is known to date about this vaccine, and what's any one of you would see in the informed consent document when we would go over it. So over 100,000 participants have received a adenovirus 26 based vaccine. And I highlighted the based vaccine to share that it's the same platform that is being used for the COVID vaccine, but these are vaccines for other infections like Ebola or CMV or other infectious illnesses. So think of it as this is the backbone which has been looked at in over 100,000 participants, but then the brain, which is the different viruses, is not part of what I've shared here. So in that, with this backbone, the side effects seen are what one would expect with an injectable vaccine, and which are not uncommon with vaccines such as for the influenza. So injection site reaction, headache, chills, joint pain. I share with my participants and I remind myself that side effects do not happen to everyone, but we don't know upfront who they will happen to. It's important that we share what is known. It is important that we closely follow our study participants. And it is important that for each thing that they experience, we say, is it related to the vaccine? Or is it unrelated, as in could be related to something else, and then share with them what that something else could be. Typically, these reactions are short. As of 10th September, so last month, over 800 participants 18 and older have received this particular vaccine as part of the phase 1-2 trial. And again, fever, muscle aches, and headaches have been the common side effects in those who have had side effects. And again, not everyone has side effects. And they can be severe, they are short lasting, they appear to be more in those who are younger. It may be because their immune system responds more strongly to the vaccine, but it's not clear. But from that, and this is a good example of how we would discuss when doing an informed consent, we would share this information. We would share that based on this experience, for those who participate in the study, if they start to get a fever or muscle ache or a headache, don't wait for it to get more. Go ahead and take a fever reducer or pain reliever. So the question about how do we as a participant learn about what's happening, this is a good example, which is when something's learned, then it gets incorporated in a consent. When more is learned, it so goes on. And the current study, which started enrolling on September 21st, is in its first safety pause on since October 11th. And it's again important to dwell on this because it shows what research looks like in contemporary times. And regardless of which politician has promised what date for the vaccine to be approved, it does not happen that way. And so safety pauses are pre-designed rules that are built into a trial, which is if there is a side effect, if the side effect results in a hospitalization, then the investigators say, could it be related or not related to whatever is done, in this case, the vaccine. If there is any chance that it could potentially be related, then a safety pause, depending on the severity of what the side effect is put into place whereby the trial is paused. Then a group of independent investigators get all the details. They make a determination along with the site investigators to say, as we got more information, we feel that this particular side effect was most likely related to such and such and not related to the vaccine. Or they may say, based on everything we have, this appears to be very much related to the vaccine. Depending on what the side effect is and what the decision is, then the study either is unpaused and starts as usual, or it is modified based on incorporating information from what was learned, or it is totally stopped depending on what it is. Why I spend time on this is in the news we see this trial has a safety pause. The Eli Lilly trial has a safety pause. The AstraZeneca trial has a safety pause. And someone may say, this must be a very risky vaccine. But what we have to realize is that these are two different vaccines and one different medication, but they are all of interest appropriately to the world because they are related to COVID-19. But these pauses are very much to be expected when research trials happen. These are the safeguards of research trials. I would go ahead and say, if you have a large clinical trial where there is no safety pause, that should give us pause to say, how come something was never stopped in between to say, could a side effect have been related or not? So again, to underscore, there are all these checks and balances which are very appropriate. It's easy for me as a clinical researcher to normalize it, but it is important for all of us to understand this so that we can be most informed as well as can be good ambassadors of spreading this information to others. Other points to note about the Ensemble trial is, as I had mentioned, but there is never overemphasizing, the informed consent is a process. So say one of you were to want to be part of this clinical trial. Today you learned a little. That slide on safety was just one small section of a 28-page informed consent document. Those 28 pages have valuable information, but it's not practical to say someone can concentrate on 28 pages immediately. So we share information early on, we talk to participants, we send them the consent document, they can read, they can discuss, they can ask questions. That process continues on until the participant is satisfied and then signs the consent. Them signing the consent does not mean that it cannot be reversed. At any point, which may be the next day, they may say, we don't want to participate in the trial, and they can come out of trial. And it's important that we continue to share information with them as the trial goes on. It has a relatively slow study visit burden with about 5 study visits in the first year, 2 in the second year, 1 intramuscular injection. There is an electronic diary on the phone or on tablets that participants can use to say twice a week, do you have any illness? If it's no, that's it, it's done. If they say yes, then there are questions of, do you have headache, do you have fever, all done on a phone or a tablet. And then based on those, if there are any COVID-19 symptoms, then they are provided swabs such that they can collect the first sample at home and then get COVID tests done by staff. And at the end of it, if they have COVID, they're carefully followed to see how they did. And that's the information while they continue to get their normal standard of care for COVID-19. And that's the information which informs whether the vaccine is effective or not. And again, important to know that the trial participants can come out at any time. Participants are compensated for their time. It's a monetary compensation, but it's always, regardless of the amount, considered a token because altruism does not have a dollar value to it. And there is always, in our experience, an element of altruism that is part of the participants that volunteer for clinical research that we conduct. The trial we hope to open to enrollment as soon as the safety pause is lifted. We encourage those who are interested to go to this website, and I have this website leads to this web page. So it's www.preventcovid.org. On which there is a tab for volunteer. This is a website which anyone in the United States would see when they showed interest for a trial. That registry is common to the United States, and then centers like ours can then download the information of volunteers from our area for whatever trial is open at that time, and then approach them based on the trial slots that are available. Our goal, with the backdrop of sharing information with you from our county as to who is at risk, not just of COVID-19 infection, but of having complications or morbidity and mortality related to COVID-19. Our goal is to take the information about this study, as was shared with you, to those most at risk. And so with that, how you can help is by asking questions, by advising us about what was it about this overview that could be included to make it more balanced and informative. And then by requesting you to share information about this study with those who you interact with. To help address today, as well as on an ongoing basis, the understandable anxiety about vaccines or research in general. And in the meantime, to continue encouraging the wearing of masks, physical distancing, and practice of hand hygiene. This is a quote which Andrea, you shared with me, and it is so reflective of what we see going on, whether it's for vaccine development or other ways in which the world is responding to this pandemic. And this is the website again, which we encourage you to check out and to volunteer at if interested. So with that backdrop, I'll request Lizzie and Lauren for you to share questions with us. And Andrea, if you could take it from here to add to what I shared, but as well as talk to this ongoing discussion that you're leading in the community on this topic.
Absolutely. Thank you for that information. And I know one of the questions came in that was specifically asking about how would we be able to get the information out to community members in a way that it spoke to all of the concerns and the needs and the challenges that we know exist. And I just wanted to respond by saying that we have aligned ourselves with a few local and national groups. And we plan to garner their support and assistance to bring relevant topics that will better help us understand the challenges and barriers to recruitment for vaccine studies. We know that the trust piece is getting lost in the urgency to enroll people onto the study. We also know that there are centuries of mutual distrust over medical research, and it still exists to this day. And so we know that there has been a sad and brutal history of exploitative experimentation for Black and for Brown and for Jewish people, for poor people, for imprisoned people, and for those who are lost and often forgotten. But my hope is that a series of virtual community talks and presentations and YouTube videos and educational materials can help to shade down some of the very real and perceived fears that exist in our community. So starting tomorrow, I will be hosting a community talk entitled, Let's Talk About What a SARS-CoV-2 Vaccine Can Do. And I will break down what a virus is, what it looks like, what a vaccine is, and what a vaccine will do to beat COVID-19 if successful. So I'd like for us to really break it down to the very minute details and get an understanding of what it is that you're being asked to do and provide community members with the knowledge and understanding so that you can intelligently make a decision about how you'd like to commit to a vaccine study, and even not committing to a vaccine study, but how you may respond to when vaccines are actually safe and approved for community use. Also tomorrow, I will be meeting with Dr. Alpha Stewart. She is the Senior Associate Dean for Community Health Engagement at the University of Tennessee Health Science Center here in Memphis. She is doing a talk right now as we speak for the Tennessee Department of Health's Office of Minority Health and Disparities Elimination on how health disparities and inequities such as childhood trauma, adverse childhood experiences, racial trauma, and also psychological trauma of racism impact African American communities, and how these things will actually have impact on our overall medical health. I'm also meeting with Dr. James Childress. He is the CEO and president of Meharry Medical College. He has a background in infectious diseases, has done great work within the HIV and AIDS community, and he's leading COVID efforts for testing in Nashville. And Meharry will be one of the historically Black colleges and universities embarking upon upcoming COVID-19 studies. They have 2 in the community of Nashville, and Meharry will be leading one of those, along with 3 other HBCUs. The national coordinators for our COVID vaccine prevention network have been talking with me, and we have been working and thinking about how else to reach faith and clergy leadership within our prospective networks. And so there is a dialogue happening right now with Dr. Edwin Sanders, who is the pastor of Metropolitan Baptist Church in Nashville, and he will begin to develop programming and talk and just know how to better reach communities of color and talk about those things that we know need to be talked about in order to move forward with acceptance of vaccines. I'm also working with Drs. Paul and Patricia Juarez. They're leading statewide efforts called CEAL, C-E-A-L, Community Engagement Research Alliance Against COVID-19 in disproportionately affected communities. And so this group will set up testing hubs across the state of Tennessee and also provide information hubs to address matters such as vaccine trust or mistrust in other educational sessions. And so we're trying to develop programming that will allow your questions to be heard, that will also create this space of safety and be able to really talk about it in a calm, in a very thoughtful, in a very honest way, so that we can be able to build our capacity and understanding around vaccines and why they are needed in our community. So I think that's all I have. A good day.
Awesome. Thank you so much, Andrea. We really appreciate everything that you guys have done to help us out today. It looks like we have about 2 minutes left, so I'm going to go ahead and wrap us up. Just to remind everybody, we are going to send up a follow-up email to the email that you used to register for this webinar. Hopefully we can get with Andrea and Dr. Gar to come up with a more comprehensive written list of everything that she's been announcing so that y'all can know when to participate, how to participate, and also have contact information for any follow-up questions or concerns that you have. Thank you both so much. You've actually answered all of our questions that were submitted. So I think that if anybody else doesn't have any follow-up questions, then we can go ahead and say thank you for sharing with us today. And everybody be on the lookout for follow-up information about the vaccine trial. Thank you guys so much. Okay,
Thank you.
everybody have a great day.
Thank you.
You too. Bye-bye.